welcome to today's webinar, Changing Relationships, How to Foster Effective Communication with Patients and Families. My name is Jennifer Golden-Petrie. I'm a Program Coordinator at Family Voices. This webinar is the second installment of the 2016 webinar series entitled Thinking Outside the Box, How to Advance Health Equity and Care Quality in the Pediatric Medical Home. This webinar series is presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau of Health Resources and Services Administration. Before our faculty begin, I'd like to inform you of some housekeeping items. The slides will appear in the central window of your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the question box window on the left-hand side of the screen. These questions will be answered at the end of the presentation. If we do not have time to answer your questions during the webinar, we will send you an answer directly via email at a later time. This webinar will be recorded and archived on the National Center for Medical Home Implementation website approximately 1 week after this presentation. After the webinar, you will receive an email with a link to a webinar evaluation. We encourage you to complete this evaluation so that we can continue to improve the content and manner of our presentations in the future. Today's presenter has no conflict or financial of interest disclosures to announce. Today's webinar has 3 learning objectives, including the following. Describe how health literacy and language access can improve delivery of care within the pediatric medical home model. Discuss evidence-based and evidence-informed promising practice that leverage effective communication and language access to improve equitable provision of care. And 3, to identify effective visual, verbal, and written communication tools and resources that can be used and practiced for all patients, including those with limited English proficiency and health literacy. And now I'm honored to introduce to you today's speaker, Shauna Yin. Dr. Yin is a general pediatrician and an assistant professor of pediatrics and population health at the NYU School of Medicine, Bellevue Hospital Center. She is an NIH-funded researcher focused on examining the impact of parent health literacy on children's health and has substantial expertise in the development of health literacy-informed interventions. Dr. Yin?
Thanks for the introduction. It's a real pleasure to be talking with you today. As mentioned, I spent a lot of time thinking about issues around provider-family communication, and for over 10 years I've worked at Bellevue Hospital, which is affiliated with the NYU School of Medicine and is considered the flagship public hospital in New York City. And it's been my work with the patients and the families there that has led me to become interested in issues of health literacy and health communication. Next slide. So today I'm going to focus on core principles of provider-family communication and strategies you might employ in your clinical setting. I'm going to focus on optimizing communication, thinking beyond simply communicating with a family in the language of their preference. It's really clear that addressing health literacy and language access is critical to improving delivery of care within the medical home model. These concepts are interwoven in the core tenets of the AAP's pediatric medical home model. Without good communication, one cannot develop a trusting partnership with families. One cannot share clear information and options about a child's medical care and management. One cannot effectively provide counseling on health, safety, nutrition, and other key issues. Without good communication, you would struggle to identify and address a child and family's medical, educational, developmental, and other service needs. Next slide. Without good communication, you would struggle to coordinate care with other services and specialties, and you would have difficulty expressing concern and empathy. Without good communication, you would have trouble with providing culturally effective care. How would you be able to recognize, value, and respect a family's cultural background and incorporate it into your care plan? How would you ensure child and family understanding? There is no doubt, of course, that for good communication, interpretation is necessary, and written materials should always be provided in the family's primary language. Next slide. Before we start talking about key communication strategies, I want to cover a little bit of background. One of the reasons we're focusing on the issues of health literacy and limited English proficiency today is because these are very commonly encountered issues. Low health literacy affects about 1 in 3 U.S. parents. Next slide. This pie chart shows national data related to health literacy. The data comes from the 2003 National Assessment of Adult Literacy. And as you can see here, about 30% of parents fall into the areas shown in red and in orange, which represent below basic and basic health literacy. And that translates to about 21 million parents in the U.S. But one thing that's really important to point out is that only 15% of parents fall into the green part of the pie, the part that represents proficient health literacy. A good chunk of parents fall into that yellow intermediate level, which means that they still struggle with health literacy issues. Next slide. Limited English proficiency affects about 1 in 10 U.S. adults. And it's well recognized that issues of low health literacy and limited English proficiency are closely intertwined, with a disproportionate percentage of low-income and immigrant families affected. We know from prior studies that those with both low health literacy and limited English proficiency are at particular risk for poorer outcomes. Next slide. A few definitions before we go on. Limited English proficiency has traditionally been defined using the question, how well do you speak English? With answer choices of very well, not well, and not at all. Those who answer very well are considered English proficient, while those who answer any other way are categorized as being limited English proficient. Next slide. So why do we care about limited English proficiency? Studies have shown that children from families where limited English proficiency is an issue are more likely to have worse health knowledge, poor disease management, worse quality of life, decreased access to quality care, and greater dissatisfaction with care. Next slide. Now a quick word about the definition of health literacy. Many people think that health literacy just means literacy in a health context. But health literacy really goes beyond the ability to read and write within the context of health. Health literacy is defined as the degree to which individuals have the ability to obtain and process health information, and to take that information to make informed health decisions. And it encompasses the ability to access and navigate the healthcare system, which includes being able to apply for and obtain health insurance, for example, as well as to figure out how to get to their doctor's appointment. Next slide. So why do we care about health literacy? Numerous studies have been done linking low health literacy to decreased knowledge, worse health behaviors, increased use of healthcare services, as well as poor child health outcomes. Next slide. When one thinks about health literacy, though, it's important to think beyond the skills and the abilities of individuals. One typically thinks of health literacy as being at the intersection of what a patient and their family brings to the table, which is shown in the yellow arrow here, and what we as a healthcare system bring to the table, shown with the red arrow here. With respect to the demands and complexity of the tasks we ask the patients and the families to take on. Next slide. So when you dive into this model, you can see how an individual brings in their skills, shown here in yellow, their prose literacy skills, which refers to their ability to read and understand continuous text, their quantitative skill, which refers to their ability to understand numbers, such as risk and benefit information, and their document literacy skills, which refers to their ability to navigate things like a nutrition label or a medication label or an immunization chart. Individuals also bring their prior knowledge of health and the healthcare system. Next slide. We as a healthcare system then bring in printed and spoken messages of varying levels of complexity. Next slide. And where the two intersect is health literacy, shown in green. Next slide. And when the relationship between the two is optimized, we envision that there is increased knowledge, improved self-efficacy, behavior change that ultimately leads to improved health outcomes. Next slide. So I'm now going to spend the rest of the talk focused on key communication strategies for those with low health literacy and limited English proficiency. There are three main aspects that I'm going to focus on. Number one, creating a shame-free environment. Number two, improving verbal communication with parents and patients. Number three, supplementing verbal communication with written materials and other resources. Next slide. These are part of a recommended universal precautions approach. Next slide. So what does that mean? The idea is that everyone benefits from clear communication. Many patients are at risk for misunderstanding health information, and you can't tell by looking who those people are. Even someone with a high level of education may have difficulty understanding because of the context of the information. So someone who is a physician, for example, but whose family gets diagnosed with cancer might not have good health literacy in that particular topic area. And also there is an impact of stress, which can affect the way information is received and understood. Obviously, you want to convey information in the patient and family's preferred language. You want to ask the family, what language would you like us to use today? Or what language do you usually speak at home? You want to be careful so that families don't feel that it is inconvenient to have an interpreter come. You don't want to say things like, so is it okay for us to talk in English? Or your English is great, can we talk in English today? You want to keep it open-ended and not make any assumptions. Assessing health literacy in the clinical setting is not recommended. It's recommended instead that this universal precautions approach is used. So basically, you should use plain language, health literacy-informed communication strategies with everyone. And remember, when plain language and clear communication principles are used, this helps everyone, and even when you work with families with LEP and have an interpreter involved, starting with clear communication in English means that you are helping the interpreter to communicate more simply and effectively. Next slide. Let's focus first on the environment, this concept of a shame-free setting. Many families with low health literacy or limited English proficiency feel ashamed about their status, and it's important to try to help make their medical home feel as welcoming as possible. When individuals with low health literacy or LEP feel comfortable, you're far more likely to be able to communicate effectively with them and provide high-quality care. I'd like each of you guys to think about the environment where you work. Is it easy for patients to check in, make appointments, get referrals? What do those forms and handouts you use look like? Are you able to provide help confidentially? Have your staff been trained to be sensitive to patients with low health literacy or language difficulties? Do they know how to recognize communication red flags? Next slide. Some of these red flags include things like incomplete registration forms, missed appointments, non-adherence to medicines, excuses when asked to read things like, I forgot my glasses. Next slide. To examine your own site's communication environment, you can use the assessment tool that's in this AHRQ toolkit to systematically look at where there are deficits at your site and come up with a plan to address them. The AHRQ Universal Precautions Toolkit also has a lot of other helpful information on tools and strategies to improve verbal as well as written communication at your site. You can see the link here. Next slide. I'm going to now shift gears and talk a little bit about verbal communication. Some key verbal communication strategies are number 1, listen, number 2, simplify, and number 3, ask for teachback. Next slide. Many times, people forget about the importance of listening as a key communication strategy. It's so important to listen for the child or parent's agenda and to encourage questions. How do you encourage questions? Well, you don't want to say things like, do you understand? Or do you have any questions? As invariably, the patient or the family will nod yes, that they understand, and no, they don't have questions. Instead, you want to ask, what questions do you have? This normalizes the concept of patients asking questions. Next slide. Number 2, simplify. You want to use plain living room language, the kind of language you might use when you're talking to a family member or your grandmother. You want to use simple words and short statements. You want to use analogies that might help patients and their families visualize. For example, arthritis might be compared to a creaky hinge on a door. You want to focus on 3 or fewer key action items. That's about all that a patient or their parent or the parent can retain. You want to slow it down, and you want to avoid medical jargon. It's so easy to fall into the trap of using jargon, and oftentimes you just don't realize that you're using jargon. Next slide. If you're a clinician, you may want to set aside one clinical session and keep track of the medical words that you often use with patients, and then see if you can come up with a simpler way to say them. Next slide. Instead of benign, could you say normal? Instead of chronic, can you say happens again and again? Instead of cardiac, can you say heart? Instead of edema, swelling? Instead of negative test, can you say normal result, etc.? Next slide. Number 3, use teachback. I think most people here have heard of the concept of teachback. When you present a new piece of information, you want to explain the concept and then assess patient comprehension. You want to assess comprehension not by asking a patient, do you understand? Or to ask, just repeat back what I just said. Instead, you want to ask them to tell you in their own words what they understood of what was just talked about. And if it doesn't seem like the patient or the family understands, you would then clarify and then reassess communication. And this would continue until the patient or the family member shows that he or she understands. You want to be sure to close the loop of communication. Next slide. And don't forget to chunk and check. That means you want to make sure that you don't present too many concepts at once before you do the teachback, as this can be overwhelming to the patient. You should try to chunk information into bite-sized pieces and do teachback on each piece separately. Remember that you don't have to do teachback on everything, just on the key action steps you want your patient or the patient's family to remember. Next slide. So why should you use teachback? One reason is that you will likely be shocked by the number of patients who you thought understood but didn't. The benefits of teachback are really clear. Teachback is considered one of the top patient safety practices by the AHRQ. It's been studied and found to be associated with improved patient outcomes. A study by Dean Schillinger found that teachback was associated with improved glycemic control, for example. Teachback has also been found to improve informed consent. But unfortunately, most providers don't use teachback regularly. Next slide. So one reason why providers might not use teachback is because they may feel that it's awkward to do. It may feel condescending, like you're testing the patient. And I've trained many providers in teachback and talked to many health professionals about teachback. And the bottom line is really that it's all in the way that you ask. A few strategies that I've found that works really well is to put the pressure on yourself, not the parent or the patient. So for example, you can say something like, I'd like to make sure that I did a good job explaining this to you. Can you tell me how you plan to give the medicine to Christopher when you get home? You want to incorporate teachback in a natural way, not as if you're testing the patient. So for example, if there's another caregiver that may be involved in the care of a child, you might say something like, what will you tell Jennifer's father about what to do when her asthma gets bad? Or we talked about a lot of different ways to cut down on giving juice to Joey. What are some things you plan to do that will work for you at home? Next slide. Some people complain that teachback takes too long. And in the beginning, as you're getting used to it, you may feel that things are taking longer. But most doctors I've trained and worked with say that after a while, it just becomes a part of their routine and it's faster and smoother. In addition, it might even save time to do teachback because it means that patients are less likely to call you later or to need another appointment later because they got confused. It may feel daunting to incorporate teachback in every encounter in the beginning, and you may want to choose a certain clinical session to do teachback or pick certain topics you want to do teachback with. For example, when you prescribe a medication, this might be a great opportunity for teachback. The task of giving medication is a confusing one for many families. It involves different skills like prose literacy, document, and quantitative literacy, and parents have to understand concepts around dose, units of measurement, dosing tools, frequency, duration. And so this would be a great place to start doing teachback with your patients. When doing teachback with medicines, you may also want to consider doing dosing demonstrations and having the parent show back the dose to you. Next slide. This slide, which comes from a study by Mike Wolf's team, really illustrates the importance of a showback. The research team assessed patient understanding of the SIG, take 2 tablets by mouth twice daily. And you can see that the rates of understanding across health literacy groups, shown in the black bars, seems to be fairly high, with those with low health literacy having the worst levels of understanding. But when patients were asked to demonstrate their understanding by counting out the pills that they would give in one day, you can see that many patients struggled, especially those with low health literacy. Among those with low health literacy, next slide, 70.7% seemed to understand, but only half of those, 34.7%, actually were able to demonstrate understanding. So for liquid medicines, you can imagine how you might show a parent how much medicine to give using an oral syringe, and then ask a parent to show back the dose using the syringe to really get a really good sense of their understanding. Next slide. So I'm now going to shift gears and talk about going beyond verbal communication strategies to thinking about written materials and other tools. We know that print materials and visuals can help improve patient understanding and recall. We also know that patients prefer messages with accompanying print materials and visuals. The thinking is that print materials and visuals incorporated as part of verbal counseling help reinforce verbal messages, and photos and drawings can be especially helpful. When I mean as part of counseling, I mean that the provider and patient are actively looking at the print materials as the provider is counseling. The provider should be pointing to key messages, circling, underlining, highlighting key points, such that when the patient and the family get home, they have something tangible to look at, something that can help refresh their memory about what was being emphasized as part of the provider-parent encounter. Next slide. There are a number of cognitive science theories that help explain why written materials and visuals can help. The cognitive load theory indicates that it's important to account for the cognitive limits of individuals. So whenever possible, you want to bypass the limits of a person's working memory, also referred to as their short-term memory. There's really only this limited space in a person's working memory. And in order for something to get into a person's long-term memory, you need to first initially have the information processed through the person's short-term memory. And many people have heard the example that phone numbers were made to be 7 digits because of the limits of working memory. I think many of us struggle to even remember a 7-digit phone number when someone verbally tells it to us and would much prefer to have it written down. So what you really want to do is avoid reliance on a patient's working memory by using written materials. You also have to be careful to minimize extraneous cognitive load. You want to focus on key takeaway points, and even with drawings, you want to stay simple. Next slide. So why add cognitive burden with a detailed anatomical diagram with the stapes, malleolus, and the incus when a simpler, much more friendly, patient-friendly, and straightforward version would suffice? You can see that example on the right. Next slide. The dual code theory is another theory from cognitive science. The concept is that there are separate channels for text audio information and visual graphical information. So if you present words and graphics simultaneously, the thought is that you can improve information transfer. Next slide. So let's take a moment to think about the print materials where you practice. How easy is it for your patients to understand and take action on the print materials you use? Think about the materials you use for counseling, the patient education materials, the discharge instructions. What about other communications? Patient portals are becoming more and more common. What about letters you send out to families and the forms you ask patients to fill out? Could what you're using where you practice be improved? The likelihood is yes. Next slide. Prior studies which have looked at commonly provided handouts show that the documents that we use in pediatrics are often written at way too high of a reading level. AAP tip sheets, some of the CDC VIS sheets, S-CHIP enrollment forms, etc. Next slide. The general recommendation is a 6th to 8th grade level for the general population and a 3rd to 5th grade level for lower literacy populations. Next slide. You may wonder, how is reading grade level determined? Well, there are lots of different readability formulas. Some are shown here on this slide. And one of my favorites is the SMOG, or the simple measure of gobbledygook. Most of these formulas are based on the number of words and sentences and the number of difficult words or multi-syllable complex words. Next slide. Don't worry, you're not expected to calculate grade level, the grade level of every document by hand. They're free online readability calculators where you can cut and paste text to find out the grade level. Even Microsoft Word has a tool to assess readability, and you can see the instructions on how to do that here. And just to remind people, these slides will be available at the end of the presentation, so don't worry. You can look at these in detail later on. The only thing you have to be careful with in terms of Microsoft Word, if you can click to the next slide, is that the formula that it uses primarily is the Flesch-Kincaid, which has a tendency to underestimate reading levels. Next slide. Typically, people will say that you need to add 1 to 2 grade levels to what is shown. So if it says 9.3, it might be more like 10th or 11th grade. Remember, you don't need to check every single document being used where you practice. You might want to check a few, or you might want to enlist some colleagues to help. Next slide. But finding the right plain language print materials really goes beyond readability and grade level. The goal is to find plain language print materials which are designed such that they focus on key points, they focus on the need-to-know information versus the nice-to-know information. They really emphasize what the patient should do. And they include simple, realistic, purposeful illustrations or images. Information about things like pathophysiology and causes are typically minimized. Next slide. Plain language materials use simple words, short sentences, short paragraphs. They divide and chunk information using headings and bullets. They use a lot of white space, and they avoid medical jargon whenever possible. Next slide. There are a number of tools that you can use to assess patient education materials. The PMAT, which is the Patient Education Materials Assessment Tool from the AHRQ, can be used to assess both print and AV materials, and you can easily download this tool from the web, and it uses an Excel spreadsheet to help you calculate a score. Next slide. There are 2 main categories that the PMAT assesses. The first is the understandability of the document, which includes assessing for things like distracting content, use of everyday words, avoidance of jargon, use of an active voice, use of numbers and avoidance of the need for calculations, chunking of information, as well as the effective use of visual cues and visual aids. Next slide. The second area the PMAT assesses is actionability, and that includes how action steps are broken down into explicit, manageable steps, and includes the use of tools like charts, graphs, diagrams, and other visuals to help make it easier for people to take action. Next slide. The SAM, or the Suitability Assessment of Materials, is another tool you can use to assess materials. This tool dives in deeper and gets into the real nitty-gritty of font size, font types, line lengths, etc., and even covers cultural appropriateness. And while it may be a little bit too detailed for many of you to use on a frequent basis, it's helpful to get a detailed sense of what makes a patient education material really great. And it's the framework that I've used in designing a number of health literacy-informed interventions. Next slide. So now I'm going to give you some examples of good plain language materials. A few years ago, the AAP formed a Health Literacy Project Advisory Committee, and this was led by Bernard Dreyer, who is now the current AAP president, and Marianne Abrams. And one of their projects was to create plain language versions of existing AAP handouts. They did this for 25 different topics. Topics covered included asthma, bronchiolitis, diarrhea, ear infections, ADHD. And the new plain language handouts are all one-page handouts, front and back, and they're available in English and Spanish. And they really adhere to the principles of plain language. So I'm going to show you some parts of these handouts. Next slide. So here's an introductory passage from an original handout on diarrhea. You can take a few minutes to read it. Most diarrhea in children is caused by one of several diarrhea-causing viruses and gets better by itself within a week. Although there can be many causes of diarrhea, the treatment suggested here is appropriate for acute illness, parentheses, sudden onset, short-lasting, close parentheses, which occurs most commonly. A child with viral diarrhea has a fever and often starts the illness with some vomiting. Shortly after these symptoms appear, the child develops diarrhea. Often children with viral diarrhea feel bad but do not act ill. And so you can see how the original handout had more kind of passive voice, less engaging, and then I'll show you an example of the plain language version of the handout. That's more engaging, uses active voice and conversational style. Diarrhea, or loose poop, and vomiting or throwing up are why many parents call the doctor. Your child's doctor may call this gastroenteritis. These symptoms are often caused by a virus. There's a star that goes down to a little definitions area to explain what a virus is. Your child may first have a fever and some vomiting. Diarrhea often starts later. The symptoms usually go away in a day or two, but they can last a week before getting better. Next slide. You can see this is examples of the words to know on the bottom of the page to help explain difficult words that parents may hear. Next slide. This is an example of the plain language handout on ear infections. And what the parent needs to know to do is right up front after a very short introduction, and it isn't until much later that there is an anatomic diagram. The original handout had the anatomic diagram on the first page. It was the one I showed you earlier with the details on the incus, the stapes, the malleolus, etc., not what the parent needs to know to take action. Next slide. Next slide. In developing the plain language handouts, there was a big focus on trying to pare down information so that things were not too overwhelming. So for example, this original handout on children's medicines was 4 pages long in small font with limited white space, and it ended up becoming 4 separate handouts. Next slide. Next slide. There's one on prescription medicines, one on over-the-counter medicines. Next slide. One on choosing over-the-counter medicines for your child, and one on using liquid medicines. And having separate handouts meant that each could look more patient-friendly with more white space. Next slide. With the new AAP handouts, there was also a big focus on inclusion of simple, purposeful illustrations. This was an example of an original handout for RSV, and you can see the image here is of a mother carrying a baby to the hospital. Next slide. Here is the plain language version of the handout, and you can see here that this image is better in that you can really see the mother who's comforting this child. You can see the child's ribs pulling in and showing the respiratory distress that he's in. Which image do you think is more informative? Next slide. The top part of this slide shows the top of an original asthma handout. And the bottom one is from a plain language handout, which shows a child using her spacer with inhaler. You can see how the plain language version reinforces the use of a spacer, the proper use of a spacer, and helping parents take appropriate action. Next slide. Here are a few more examples showing how plain language handouts use simple, purposeful illustrations to show how to take a child's temperature. Next slide. How to administer and measure out medications. Next slide. And this is an image used in one of the plain language handouts showing how to use a nutrition food label to check for dietary fiber. Next slide. So I'm now going to talk about some other examples of good print materials to use to supplement verbal counseling. The HealthPix medication instruction sheets were developed by my team at NYU School of Medicine and Bellevue Hospital a number of years ago, and these are patient and medication specific, plain language pictographic instruction sheets which are meant to be used as a framework for counseling and are given to parents to take home. One of the key components is the pictographic dosing diagram, which shows exactly how much medicine the child should be given within a dosing tool. There's also a log underneath that which shows parents, helps parents keep track of when to give medications. Parents work with the provider and they discuss what times would be good to give the medicine based on the parent and child schedules. The first and the last doses are circled by the provider to ensure parents understand that the medicine should be given for the full course. Dose demonstration, teach back, and show back of the dose, and provision of an oral syringe are also part of the intervention, which takes only about 2 minutes to do. Next slide. A randomized controlled trial of HealthPix with English and Spanish-speaking parents in New York City Public Hospital Emergency Department found a dramatic reduction in dosing errors with HealthPix, as well as improved rates of adherence. Next slide. HealthPix is featured in the AAP's Plain Language Pediatrics book, and there are generic sheets available in the book as well as online. We're currently working on an app that will soon be available in the upcoming year. Next slide. Many people like the What to Do series from the Institute for Healthcare Advancement. There was an evaluation which was done which showed that these plain language books, when given to parents and when the parents were taught to use them, there were fewer ED visits, fewer doctor's visits, and fewer school days missed. Next slide. So I couldn't resist but give one last cognitive science pearl to reinforce the idea that you want to use visual modalities to present visual concepts. For print materials, drawings, photos, and beyond, for example, videos, may be what leads to the most effective learning by patients, parents, and their families. So for those of you who are providers or who are the ones who choose the patient education materials for your clinical site, think about what would be the most optimal way for families to learn about each of the topics you counsel about. Next slide. An example of where photos have been very effective is the Green Light Toolkit. And this was created as part of an obesity prevention intervention targeting young children. Low literacy materials are used to facilitate effective provider-parent communication at each well-child visit from 2 months through to the 15 to 18 month visit. There was also provider training and health communication strategies such as use of plain language, teach back, and goal setting. And the toolkit was developed as part of this NIH-funded R01 study and is being studied as part of a cluster randomized trial. I'm one of the PIs of this multi-site study, and I led the development of the toolkit. Next slide. So you can imagine for an obesity prevention intervention how images are so very important. We very, very carefully chose images to support the text. This is one example from our 2-month-old booklet. You can click. So on this tummy time page, you can see an image of a young baby doing tummy time. And you see how uncomfortable he looks. And this, I think, it reassures parents that their baby might look a little bit uncomfortable doing tummy time, but that they should still give tummy time a try. Next slide. We were also very, very careful about the photographs of food we included. And in fact, we couldn't find stock photos of food that were acceptable, so we ended up doing a food photo shoot so that we could find the right portion sizes of food cut to the right size for the child's age. Here are examples from our 15 to 18 month booklet. Next slide. And here's another example from our 9-month booklet. You can see images of possible finger foods to try, as well as a sample menu. Next slide. Finally, I wanted to show the Green Light Toolkit because of the tangible tools we included. These tools provided tangible models for parents to reference. So for example, at the 12-month time point, we gave parents portion-sized snack cups to reinforce the right portion size for that age, as well as to promote healthy snacks. So for those of you who are providers on the call, think about whether there are certain topics you counsel about that could benefit from the inclusion of models or tangible tools. Next slide. If you want to learn more about Greenlight, you can look at this reference describing the study in pediatrics. Next slide. The last thing I wanted to show you is an example of an intervention strategy incorporating videos. My team recently developed the HealthX Asthma Action Plan, which are asthma action plans that are patient and regimen specific, use plain language, and use pictograms and photos to help reinforce concepts. Providers use a web-based application to generate the instruction sheets, and the action plan is then used as a framework for provider counseling. Providers can then email the action plan for parents to refer to at home. And embedded in the action plan are links to videos on the use of inhalers with spacers, specific to the child's prescribed dose. And I won't have time to show the video now, but later on when folks have access to the presentation, you'll be able to click on the link. If you hover over one of the little squares, as you can see there, for example, Flovent 2 puffs of spacer, you'll get to be able to access a video showing how to give 2 puffs of Flovent with a spacer. Next slide. And we really found really improved provider communication in a randomized controls trial of this action plan. Those who used this low literacy action plan were much more likely to talk about the timing of medications in a more low literacy manner, to talk about the spacer use and reinforce that, to reinforce the need for daily preventive medicine, as well as to be more concrete in the symptoms that they described on when to call and get emergency help. Next slide. So now I'm going to give you a few tips on what to do if you need specific patient education materials for a particular content area. And I wish I could tell you that you can just go to one place and find everything there, but I can't. What I recommend to do is to search online and see what's out there. See what tips there are about counseling patients on particular topics. For written materials, you can use some of the skills you learned today. Assess readability of handouts you find. Use the PMAT or the SAM checklist to assess understandability, actionability, or suitability. Talk to colleagues about what print materials or visuals they have seen and liked. Reach out to content experts or health literacy experts to find out what they've seen. And if you still can't find anything, you can post on the health literacy listserv, or you can look within the archives of the listserv for information. Next slide. Here are a few other resources to consider. The AHRQ Toolkit I mentioned earlier has lots of tools to help you implement universal precautions communication strategies in your practice, and it has also a whole list of resources within it if you're interested. Plainlanguage.gov has tips for designing documents as well as word replacement suggestions for medical terms. The Health Literacy Toolshed has a database of health literacy measures in case you're looking for those. Next slide. If you want to do an environmental scan of your site to get a sense of where your site is at baseline, you can look at the AHRQ Toolkit, tool number 2, or you can use Rima Rudd's Environmental Scan Assessment tool, and the link is shown here. Next slide. There are also resources for provider training. The AAP has a PediaLink module on health literacy, and the American Board of Pediatrics has a module that providers can do to get some Part 4 MOC credit. There's also a training on health literacy from the CDC for public health professionals, which includes a section on using numbers and explaining risk, which you may find helpful as well. I think that's it for what I have to present. I know that Jennifer has some other resources to mention. Thanks.
Yes, thank you very much, Dr. Gan. Also like to mention, well, you've got the National Center for Medical Home Implementation, your technical assistance center with lots of tools, resources, and promising practices. The National Center for Family and Professional Partnerships, linking providers and others to the family-to-family health information centers across the U.S. At that website, you can also find many tools and resources and links to state affiliates that have many resources in other languages as well. The National Center for Cultural Competence out of Georgetown University, because as you've heard today, effective health communication is as important as healthcare clinical skills. And cultural language and health literacy, HRSA, there's a website there. HRSA has put together a very excellent resource which contains health literacy tools, including PDFs, learning modules, and some videos. So we encourage you to take a look at those things as well. I would like to remind everyone that the slides will be available at the end of the presentation. And we do have a question. Are there quality measures of how clinics and providers are addressing health literacy issues of their patients, Dr. Yan?
That's a great question. There is HCAPS. There's CAPS questions where you can, there are surveys for patients to fill out that ask them about the communication that happened in the clinical setting. And I believe that there are questions for inpatient and outpatient settings, but I would have to double check on that. So the CAPS questions, CAHPS, I think.
Okay, thank you. Thank you for that question. Let's see, are there any other questions? Some people would want to know if there are plain language tools to aid with shared decision making.
That's a great question. I know that many people are thinking about those issues with in creating decision support tools and things, incorporating aspects of health literacy. I'm not sure how many resources are available in pediatrics. I know that there's someone that's worked on some shared decision-making resources for ADHD and I think some other areas. I believe Bill Brinkman is one of the people that's been involved in doing that. And so there are people working on that, and it's really important for shared decision-making that issues of health literacy and language are considered.
Okay, great. And here's a question with regard to the Greenlight materials. Are they available for download?
It's a great question. We're in the midst of creating a website where we'll be housing the Greenlight materials and making them available for download. They will be available in English and Spanish, and also we've adapted them recently for a Chinese population as well. So we have them in simplified and traditional Chinese. So we're excited about getting that resource out to people, hopefully in the next year.
Okay. And how can team-based care help with health literacy and language access?
That's a great question. I mean, I really think that all members of the team, it's really important for them to be sensitive to the literacy and language issues. And when all members of the team are sensitive to it, then I think that's really where the highest quality of care can be provided. I feel like each team member can reinforce with the other, what others are doing in terms of using plain language and making sure that patients are getting the plain language materials to take home, and that all those health literacy informed strategies are being used right from the very beginning, from when they check into the front desk to when they're getting screened by the PCA, and when they're or the nurse, and so when they're talking to the doctor, et cetera. I think that all members of the team, it's very critical to have the whole health literacy and like a health literacy sensitive environment, a shame-free environment, like I talked about earlier.
Okay, so here are a couple of questions with regard to interpreters. So the first one is, do you think it's helpful to give interpreters materials prior to the questions? And the other question is there a way to test the interpreter's understanding of materials? Maybe perhaps, let me see if I can understand, perhaps going back to teaching the interpreters. So I guess it's testing the interpreter's understanding. I guess keeping in mind that interpreters, sometimes there may be a question as to whether they're interpreting correctly for this person. So is there a way to test that, and do you give them the material prior to asking them to interpret the material? So it's a twofold question.
Great. Those are important questions. I think it would be optimal if you could give materials to you mean print materials or other educational materials to interpreter ahead of time. That could help them prepare. But I think that oftentimes that's not practical. But if it is possible, it may help make the encounter smoother. But my sense is that it's probably unlikely that you'll have the time and preparation time to do that. I think you kind of have to work under the circumstances that you're given. In terms of having the interpreter interpret what you're saying correctly, I think it's tough, but I think when you're doing the teach back, the interpreter should be doing the teach back and translating exactly what the parent is saying. So hopefully through that you could catch if they're saying something that is not correct. Also, I think if you suspect that the interpreter might not be translating right, then you could also ask the interpreter perhaps to teach back also to get a sense of what how they're explaining it, and you would obviously again do it in a non-testing kind of way, but just say, I wanted to make sure this is a really complex topic. I really want to make sure that the patient understands this issue, and if you can tell me, what you're saying in your own words, then you kind of then can check in also if the interpreter is understanding.
Okay, very good. Well, thank you, Dr. Yin. I don't believe that we have any more questions at this time. I want to thank everyone very much for your questions, and I want to thank Dr. Yen, again, our faculty member. We appreciate your time. We thank you for sharing your experiences and your expertise with us. This webinar recording, slides, and any unanswered questions will be archived about a week from today on the National Center for Medical Home Implementation website. Additionally, you will receive an email shortly after the webinar, and we will be asking you to, again, complete an evaluation that will only take a few minutes of your time. We would greatly appreciate if we could get your feedback. This has been the second installment of our 2016 webinar series entitled Thinking Outside the Box, How to Advance Health Equity and Care Quality in the Pediatric Medical Home. The third and final webinar in this series, Changing the Practice, How to Understand and Address Social Factors That Shape Child Health, will take place on June 8, 2016, 11 to 12 noon Central. Registration information may be found on the National Center for Medical Home Implementation website by following the link shown on your screen. Thank you very much for your participation.